Hello and welcome to Nolte Chapter 10. This is all about the spinal cord. So we have already done our ascending and descending tracks, so make sure you take a look at that one. That one is filled with information that's useful for the boards. And then we already went through the autonomic nervous system. So we just have a little bit left to do for Chapter 10. Here's the outline. We'll go through this bit by bit. The spinal cord is segmented. All levels of the spinal cord have a similar cross-sectional structure. Spinal cord is involved in sensory processing, motor outflow, and reflexes. Spinal gray matter is regionally specialized. We're going to look at this and we're going to call them the rexed lamina. Reflex circuitry is built into the spinal cord. And then those two bolded are the tracts and the autonomic nervous system. So we already did those. Those are separate lessons. Longitudinal network of arteries supplies the spinal cord. Spinal cord damage causes predictable deficits. Spinal cord is segmented. So when we're looking at this here, I drew out these little boxes and these little lines here in order to signify where the nerves are. So right here is going to be where the C8 nerve is. Okay, so C8 nerve, we have 8 cervical nerves, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal nerve. So that C8 doesn't really fit into our narrative when we're looking at the bones, right? We only have 7 cervical vertebra, and then we have 12 thoracic, 5 lumbar, 5 fused bones with the sacrum, and the coccyx is 3 to 5 fused bones. So why is there a C8 nerve? I don't really know why. I would have renumbered them if it were up to me, but it's not. So the C8 nerve is going to be in between C7 and T1. So then above C7 is going to be the C7 nerve, but below T1 is going to be the T1 nerve. There's always a question on this on your boards, always. Okay, so still to this day, I draw my squares, I put my C8 where it needs to be, and then I count it out. That way I don't make a silly mistake. Nice little overview here. You can see at the top the cervical nerve, C1 through C8, and then you can see where it's divided out into the cervical plexus, and then we could see the brachial plexus. You can see that cervical enlargement in order to innervate the upper extremities. You can see the intercostal nerves, inter being between, cost being rib. The lumbar enlargement, again for lower extremities this time. Sacral plexus, and then the cauda equina being horsetail, or where the spinal cord is going to end is going to be at that L1, L2 area, and then we see cauda equina after that. There's our horsetail, like a ponytail, right? Horsetail. So spinal nerves, they're considered part of the peripheral nervous system. They're going to attach to the spinal cord at those 31 pairs of roots. We see the cervical and lumbosacral enlargements. The nerves serving the upper and lower limbs are coming from there. Cauda equina is the collection of nerve roots at the inferior end of the vertebral column, so after L1, L2. Here's another picture of our cord. You could see cauda equina in the little square that's green over there. Conus medullaris, or the medullary cone, is going to be the end of it. So that's going to be at that L1, L2 area, and that little kind of bump, and then the hair, right, would come off of that cauda equina. Okay, so foramen magnum up at the top to the conus medullaris. So here, on average, it's going to be about 18 inches long. Depends on who you are, right? So that's the book definition. So you could be 4 feet tall, or you could be. I have a baby cousin that's 6'8". So they're going to have different lengths in spinal cords, but they're going to be about 2 centimeters in diameter. Again, the width of your finger is going to differ depending on who you are. So is the width of your spinal cord, but that's it on average. Nice picture of this, so we can see our, I'll take my marker here, the termination here of the medulla oblongata. So remember our brainstem, medulla, pons, midbrain, and so we know that we have our foramen magnum right here, or that magnum, big hole, right, where the cerebellum would be up here, right, and hopefully the tonsils don't deviate down, herniate down into that area, right? And then we can see coming down, this is a nice picture of the cord coming down here. You can see the little spinal nerve rootlets. You can see the sectioned pedicles of the cervical vertebra as all this is here. So it's just where it was cut. Okay, the bone is cut there. Dorsal median sulcus, dorsal. So we have ventral, we have dorsal. Dorsal's posterior. Median, just the midline. So there you go, that's better as midline. I kind of veered off here. These markers are not as easy to use as you would think. So dorsal, okay, posterior, median, midline, sulcus is the groove. We could see here, starting at the top upper right, they're just noting again where the vertebral arch had been cut. Okay, so the arch had been cut. We could see a cut edge of the dura mater. This right here, this whole membrane all the way through here. So remember, we have pia, arachnoid, dura, dura being durable, okay? Pia being pretty much just kind of stuck on the spinal cord and the brain itself. You can see that crack in the center, that dorsal median sulcus. You can see it really nicely right there. And then we can see the dorsal root. I'll get my red marker out of here. There you go. So you can see that. And then there's our good old DRG, that big bulby guy right there. Dorsal root ganglion. Dorsal root ganglion, is that sensory or motor? Sensory, exactly. Good job. Another picture here, so inferior end of our spinal cord showing conus medullaris, cauda equina, and our filum terminale, our terminal filament. Either way is totally fine. So we have our cord here, okay? And then this medullary cone, or conus medullaris area, okay? Just that end part. And then all of this here, you can see it all kind of coming in from here into here, right? And then all of this area here is the cauda equina. Okay. You can see where that's going to be able to withstand a little bit more movement and a little bit more trauma as opposed to just the cord proper here. So you can see where the vertebral arch had been cut. And terminal filament is the very end. I'll go for red here. So let me find the eraser first and get rid of some of this blue. There we go. So we go to the very end here, okay, and we follow it down. Okay, so probably this guy here. It's easier when you're in the dissection lab and you can really just kind of pull it apart and find it. Okay, so that's pia mater. Okay, so the filum terminale or terminal filament is going to be an extension of the pia mater, just like the denticulate ligaments are extensions of the pia mater. Meninges, we just saw the dura mater there, we're talking pia mater, so let's look at this slide again from our meninges chapter. So pad, pia, arachnoid, and dura, from deep to superficial. Our mnemonic is pad. They pad the brain and the spinal cord. Great. So make sure you know it's superficial to deep, deep to superficial. And when I see those test questions, I look at what they're asking, superficial to deep or deep to superficial. I write out my pad, PAD, and then I match it up. Otherwise, if I go too fast, I miss really simple questions. Okay? So we're playing that game with our boards that each question counts, right? Good, so remember that pia and arachnoid, those are thin, and we can call those the leptomeninges. Remember lepto, leptin, right? So thin. And then dura mater is the pachymeninx, or that's singular for meninges, and that is very durable. And think of a pachyderm, okay, or an elephant. I like to think of the meninges just as fascia and that connective tissue that surrounds all of our muscles and our bones. And why does a patient that has MS, when they flex their chin, why can they feel their entire nervous system shock and maybe go through their extremities as well, right? So to me, that's telling me that there is a problem with the fascial system and the meninges are tight. And then the idea of kind of getting that nice and healthy through this right here. So if you look here, right, we could see at the skin level here, superficial fascia, deep fascia, muscle, and then these little yellow balls here are fat, okay, so lipids, and our fatty acids are distributed along our fascial planes. And so we don't know this, I just speculate because I read a lot of different things, and I'm wondering maybe our fatty acids are cruising around those meninges as well. Maybe, don't know. But it would be interesting to kind of find out. So my MS patients, I make sure they have really good fatty acids, not only because their myelin is damaged or fragile, and myelin is made up of proteins and lipids, and so we need good fatty acids for those structures, but also for the idea of keeping these meninges, the fascial planes, very nice and healthy. Evidence? No. Okay. Does it hurt? No. All right, so good fatty acids are good for the body no matter what. All right, so gross anatomy and protection. So our spinal cord is protected by bone. We see the meninges, and then cerebral spinal fluid we went through in a different chapter as well. It's replaced every 8 hours. It's an ultrafiltrate, remember? So it is that blood-brain barrier. The ependymal cells are making our cerebral spinal fluid. Astrocytes help to create part of that blood-brain barrier as well, the structural aspect of it, remember? Spinal dura mater is 1 layer thick, okay, so dura. Does not attach to the vertebra, and then we see our epidural space above the dura. So that's that cushion of fat and network of veins in the space between the vertebra and the dura mater. And of note, even though we can't do lumbar punctures, I see a test question a lot of times in the boards about where do they perform a lumbar puncture, because it makes sure that we know our anatomy, right? So they're looking to make sure that you know that the cord proper ends at L1, L2, and that we want to go below that in order to do a lumbar puncture because the cauda equina gets out of the way, right? So instead of hitting my head here, right? So you see hair, hitting my head here, the analogy would be the cord. Here, my hair can move out of the way. That's the idea, okay? So that there's nothing that you can actually damage. Spinal cord terminates in the cone-shaped structure called the conus medullaris. That filum terminale extends to the coccyx. Okay, so it's that pia mater. It's anchoring the spinal cord down so it doesn't flip up like a window blind. We have denticulate ligaments, which are extensions of pia mater as well, and that's securing the cord to the sides. Then we saw the cervical and lumbar enlargements, and that was servicing the extremities. Dermatomes. So dermatomes is a very important aspect for any body worker, chiropractor, acupuncture, massage, physical therapist, anybody, right? So they're going to come in, they're going to have numbness and tingling into their thumb and forefinger. We're going to need to know that that's the C6 dermatome, right? So 6 shooter is the mnemonic on that one, right? Old time way of saying a gun kind of thing. So C6, right? And then C7. Okay, is the middle finger here. So if I were to show you 7 fingers, right? 7, that kind of thing. So we're going to learn that. So our dermatomes, so as the neural tube closes, the adjacent mesoderm, that middle area, also segments into a series of somites that will give rise to the skin, the muscles, and the bones. Okay, so each spinal nerve retains its relationship with this somite during development, with the result that the spinal segments are related systematically to the areas of skin, muscle, and bone. We call that a dermatome. Okay, so skin, muscle, bone, the dermatome. So if this feels numb and tingly or doesn't have good sensation, derm, skin. Here is the picture from our book. Okay, so dermatomes. Okay, so as I'm going to stand up here and move my chair out of the way. So my arm here, let's get me in the C5, C6, okay, that's 6 shooter. C7, okay, so if I were to show you 7 fingers, the middle finger, C7, C8 is this edge here, T1, and then kind of into the armpit, T2. Okay, so C5, C6, C7, C8, T1. I know you can't see that, but we're just going around the hand, right? So starting at the top here on the lateral aspect, 5, 6, 7, 8, T1, T2. Okay, so you just go around your hand. Let me grab my chair. Okay, so our nice chart here from Nolte giving us some clinically important dermatomes. So C5, upper arm right here. So we go, does this feel the same as this? Does that feel the same as that? Over and over again. Thumb and lateral forefinger, C6. Does this feel the same as this? Yes or no? Middle finger, C7. Little finger, C8. Nipple line, T3, T4, depending on what you're reading. Umbilicus is T10. Big toe is L5. Heel is S1. And the back of the thigh is S2. So we'll look at all of these when we look at our plexus. Cervical dermatomes, another picture for you here. So you could see C2 at the ears, C3 here, C4, and then C5 all the way down. So when you look at the chart over on the right and you see how it kind of spirals around, I really don't concern myself with this spiraling around unless we see a deficit in the fingers. So if this feels the same as this, I know everything up that line is intact. Just like electricity, right? So if I plug my lamp in and the light turns on, I know that the electricity is good from my home, right? So from the lamp to the outlet, through the circuits in the wall, to the circuit breaker, to the main grid. I know everything's working. I don't have to test each and every one. I test the outlet, great, right? So that's like testing this. I don't need to test the entire line. There's no way that this is going to be okay if this isn't. Just like my lamp wouldn't work if something further down the line was off, right? Same thing. So if it doesn't feel the same, then I like to locate the lesion, right? And kind of go all the way up. So I just kind of follow the line all the way up to the vertebra. Okay? And then knowing, is it C2, C3, C4, C5, C6, C7, and so forth, right? Don't forget about that C8 nerve, okay, in between C7 and T1. So that area tends to get stuck very easily, right? So those upper trap areas really tight, and our upper cross syndrome kind of rolling us in, so that area can have some issues as well. The one that we're really going to see is that kind of C5, C6 area, because remember how to find that. Take your two fingers and put your pointer finger on what you think might be the C7 spinous, and where your middle finger naturally falls in this line here is going to be C6. Go ahead and nod your head. You can feel that C6 diving forward and back. So that one's going to kind of take a hit, especially you can feel it that much just from nodding your head. Imagine what happens in whiplash. And so C5, C6 area, C5, C6, C6, C7 area. Lumbosacral dermatomes, okay, so these are the basics. So we see that L3, L4, L5, S1 nerve roots. So if they have numbness and tingling into any of these areas, most of the time the patient will come in and tell you that they have sciatica, because that's what we hear of, and that's fine. Just like anything in the hand is carpal tunnel syndrome, that's fine. They're letting us know what their symptoms are. We're the doctor, we're going to figure out exactly what's causing it. And it's not all sciatica, and it's not all carpal tunnel syndrome. That's the point of kind of teasing out which nerve it is. So our innervation of our major muscles, Nolte gives us a nice chart for us here. So movement, okay, so abduction is going to be, you're going to see C5, C6. You're going to see this multitude of levels here. Redundancy in the nervous system and the musculoskeletal system is important, because if there's a problem with C5, C6 can probably take over, that kind of thing. Okay, but the main one, so if everything's working appropriately, the main one that we memorize, the main one that we look at here if there's a problem, it's going to be C5 for this abduction. Okay, so C5, supraspinatus and deltoid. Okay, so abduction. And then looking there to the elbow, we see flexion and extension. So our flexion is going to be C6, our extension is going to be C7. Okay, so extension is C7. And then we can see wrist, flexion, and extension. So sometimes people get confused on flexion. I used to as well. But flexing at the elbow, we know what that is, right? That's pretty easy. We don't get confused on there because we have extension here. So flexion at the elbow, follow the wrist all the way in. So that's going to be flexion of the wrist. And then extend the elbow, and extend the wrist all the way out. That's extension of the wrist. That helped me once I saw that because our wrists are so mobile. Which way was flexion, which was extension. And so easy little trick there. So our wrist flexion and our wrist flexion, C6, C7, C8. Okay, so extension, C5, C6, C7, C8. So you can see flexion, they bolded C7. They bolded these, not me. And then extension is going to be C6, C7. Okay. Hand finger movements. Okay, so finger movements and thumb movements. Finger movements, C7, C8, T1. Thumb movements, C7, C8, T1. Okay, so when I get into the wrists and the fingers, I'm really just going to go for upper thoracic, lower cervical as my clinical approach here. And I'm going to just kind of check out what's going on in that area and see what I can do with that. Hip flexion and extension. So hip flexion is going to be sitting. Okay, so sitting. So that's that iliopsoas, major hip flexor of the body, L1, L2. A little bit of L3. Extension is glute. Okay, so inferior glute nerve. So that's going to be glute max. Okay, so glute med is going to give us more abduction than extension. So that's going to be L5, S1, S2. Knee, flex the knee. Hamstring, sciatic nerve, L5, S1, a little bit S2. Extension, quads. Okay, so L2, L3, L4. Ankle, dorsiflexion. Okay, so you lift the toes up. Okay. Sciatic peroneal. Okay, so that's going to be our L4, L5. And then plantar flexions, point. P for plantar, P for point. Point the toes. Okay, so sciatic being the tibial version here, and that's going to be sacrum. Okay, peroneal, sciatic peroneal. Remember that peroneal is also known as fibular. Myotomes. Okay, so myotomes and reflexes. Just another chart here, a little bit easier to follow because there's just one. Okay, so C5, okay, C5, C6, C7, okay, C8, C7 finger extensors, finger flexion, C8, finger abduction, squeeze my finger. Okay. And then the lower limbs, hip flexion, L1, L2, hip extension, L5, S1, knee flexion, L5, S1, knee extension, L3, L4, dorsiflexion, L4, plantar flexion. I always have dorsiflexion memorized as L5, so go for L4, L5. And then ankle plantar flexion, S1, S2. And then first metatarsal extension, L5. Reflexes, ankle reflex, we haven't gotten into that, but it's on the same chart here. So S1, S2, knee is L3, L4, bicep, C5, C6, and then tricep, C7, C8. This is just a nice little chart to kind of help you out. If you are a visual kind of picture learner, you can kind of check yourself on what you know and what you don't know. So pause here, see how you do. Here's the answers. They're blurry. I can't find a picture that isn't blurry for this. So kind of go back and forth if this helps you study. There are nursery rhymes for this. Okay, so there's mnemonics for everything, right, in anatomy, and thank goodness, right? So body reflexes according to nursery rhymes here. So 1, 2, buckle my shoe, 3, 4, kick the door, 5, 6, pick up sticks, 7, 8, shut the gate, right? So this is basically, you know, the S1, S2, ankle jerk, L3, L4, knee jerk, C5, C6, biceps, and brachioradialis. And then C7, C8 being triceps. If this is helpful, cool. If not, just bypass it. Let's look at the anatomy of the spinal cord now. So looking here, let's just orient ourselves. Spinous process, so this is posterior. We can see the vertebral body here, so there would be a disc above and below this, and then the vertebra would be stacked. And then anybody want to take a guess at what level we're at here? Are we at cervical, thoracic, lumbar, sacrum? Good. It is cervical. Why? Because we see these holes right here, right? And that is the transverse foramina. Okay, so our transverse foramen, whichever way you learned it's totally fine. So what is in that hole, right? Good. Vertebral artery, maybe vertebral artery and vein you said as well. Okay, so good Okay, so we want to watch out for that vertebral artery when we are doing rotation, rotary brakes, right? Good. So looking in here, it's the cord. We can see the classic H-shape, butterfly shape gray matter. Remember that gray matter is where the cell bodies are, and then the white matter around it there, that is where the axons are. That gray matter, we're going to look into that, and we're going to call it Rexed lamina. Then the white matter surrounding it, we're going to call those the tracks. All levels of the spinal cord have a similar cross-sectional structure, so we're going to start to look at the specifics here. So a couple things I want to point out as we do this. Here, right, we have these dorsal columns. We don't really call it dorsal funiculus. I don't really know anybody that calls it dorsal funiculus. We can call it the posterior columns or the dorsal columns, and that's usually a little bit more widely used. You can call this the ventral area. Ooh, that's why I'm a science major, not an art major, right? So again, I don't hear this called the ventral funiculus that much, and I don't usually hear lateral funiculus either, but you will hear posterior columns, dorsal columns. But we have these three sections, so lateral, dorsal, and ventral. And then we could see let's erase here so you could see it a little bit better. Then I want to show you the gray matter a little bit here too. So if you look off to the right here, so gray matter, commissure. So a gray commissure is where it crosses over. Okay, so information is going to cross over. So we have some things that come in, synapse, and then cross over and then go up. Okay, so that's where it crosses over is all that is saying there. Okay, that was touch pain temperature fibers crossing over, synapsing at substantia gelatinosa or Rexed to then spinal thalamic, but we'll get there. So we could see that commissure, okay, that's crossing over, and then dorsal horn, just this little part here, okay, ventral, just this little guy here, and then lateral, just naming directions is all. And then our mnemonic for SAD, sensory afferent dorsal, still works here. Okay, so sensory is going to come into that dorsal area. Ventral is going to be more responsible for motor and go out to the alpha motor neurons that are going to let us move. So here is a nice picture. So remember that the stain loves myelin, and so the darker purple is actually the white matter, and then the lighter part is the gray matter. So don't go off of this picture here. It's just how the stain reacts. Okay, so you could see that butterfly kind of H shape again a little bit better. And we can see our dorsal horns, the inner neurons receiving somatic and visceral sensory. Okay, ventral, motor. Lateral, we're going to see these pronounced in the thoracic and superior lumbar regions, and this is going to be for sympathetics. Okay, so thoracic and upper lumbar sympathetic. Nice little schematic here for you, real nice and simple at first. So we just get this idea of what it looks like, very simple, and then we'll start kind of piecing it apart a little bit. So we see these two lengthwise grooves. I'm going to switch to purple now. That run the length of the cord. We saw that in an earlier picture. Divide it into right and left halves. So we can see right here, posterior median sulcus. Okay, so remember this is a cross section like this, and you're seeing just that little line. Okay, so it's coming all the way down like that. And then we can see on the front, okay, this anterior median fissure area here. So a fissure is bigger, right? So a fissure is a bigger crack, right? And this sulcus is a smaller one. Okay, so look for the fissure, the bigger one, that's anterior, right? So we already know to look for the DRG, right, to kind of orient ourselves. So dorsal root ganglion, it's got the dorsal in its name, so we already know that that's going to be posterior. But what if we didn't have that? So the easiest thing to look for is this bigger space right here. That's the front, right? So anterior, you can even see an A right there, right? Or a V for ventral. And then we see this central canal right here, teeny tiny, and on that specimen, we can't even see it anymore once it's dried out. We need a fresh one to be able to see that hole there, but there's cerebrospinal fluid in there, so that's going to provide a little bit of pressure, so when it's actually, when we're alive and well, we can actually see that little bit of a hole there. Gray commissure, we got that, we're good. So these words here just for your reference. Gray matter spinal roots. So gray matter is divided into 4 groups based on somatic and visceral innervation. So this is going to be that somatosensory, so body sensory, right? So skin, muscle, that kind of thing. And then visceral, internal organs, so the heart, the lungs, the digestive tract, right? And then motor, so visceral motor and somatomotor, so movement of the internal organs and glands, visceral, and then our muscles and our bones, somatomotor. And then just a cool picture here kind of color codes it for us, so we can see our DRG here, right? So sensory information is coming in. Of course it is, right? Here is our somatosensory and then our viscerosensory, right? And then it's going up. Well, it's not going straight up, so it's going to come over into a tract. Okay, so it's going to come into a tract first and then go up. And then we'll look at those tracts in a separate lesson, remember? And then we could see this motor. So remember our corticospinal tract cruising down, right? And we're going to see synapses at the motor for wherever it's going. Is it visceral motor going to an internal organ, or somatomotor going out to a muscle, right? So C3, C4, C5 area, that is going to go out to, it's going to become the phrenic nerve, right? And it's going to go out to the diaphragm and help us with breathing. Nice picture here for us. We could see that again. Let's go for blue, sensory information coming in, little DRG here. And then let's say it is touch, pain, temperature from the arm, right? Synapsing at Rexed 2, crosses over, goes up the ALS pathway, anterolateral system, or the spinal thalamic tract, and then goes along its way, and we'll see what those pathways look like. Don't wanna go too far with you here. Or maybe it's visceral sensory coming in. Oh, my stomach is, distended. Really, like, it's usually the patient's intestines that are distended. It's going to synapse here and then go up its pathway there. Visceral motor, it was in yellow here. Okay, so coming down. And then somatomotor, we saw that as well. Oops, there it is. Corticospinal, synapsing Rexed 9, alpha motor neurons, and then to whatever the section is, C3, C4, C5, diaphragm, nucleus accumbens, that's going to go out to the sacral, that's in the sacral area, and that's going to go to the bladder, depending on where we are, right? And then we kind of look at our Merrick chart and match things up. All right, some basics here. So spinal cord cross-section, white matter, remember that is the axons. They're myelinated and non-myelinated nerve fibers. They're allowing communication with the parts of the spinal cord. So we have ascending, we have descending, and we have transverse. So some are going up, some are going down, and then some are talking to each other. We saw that, so these are just the words. And then in this gray matter here and in the white matter here, let's look at this white matter. That was our tracts, those are our dorsal columns. So this was the, if we remember very easily, so more medial on our body when we're standing in anatomical position is our lower extremities, our lower body, so legs, right? And then upper extremities, right? So just like standing here with my arms at my side, my legs are medial, my arms are lateral. And then we have the same somatotopy concept here in the gray matter, and we could see the hand, and then we could see forearm, shoulder, trunk. So again, lateral to medial anatomically here as well. Just kind of a neat picture here. So when we get confused here, make sure that you remember the basics, right? Sensory input that we can see here, integration, we're going to process it, and then motor, we're going to move. Okay, sensory, integration, motor. When this gets complex, just remember those 3 stages there. Spinal cord involved in sensory processing, motor, and reflexes. So each primary afferent fiber gives rise to main branches feeding into more than one ascending sensory pathway as well as local reflex circuits. And we're going to go through the reflex circuits at the end of this lecture. It's estimated that one single 1A afferent from the muscle spindle, so remember that chart from Chapter 9, so we saw that 1A afferents for muscle spindles, 1B for GTOs. Okay? So may give rise to 500 or more branches within the spinal cord. Many preganglionic autonomic neurons, so autonomic, remember our fight or flight, rest and digest, are located in the intermediate gray matter of some segments. Activity in these neurons is modulated by local reflex circuits and by pathways that descend through the spinal white matter from the cerebral cortex, so think corticospinal tract, and from various brainstem and diencephalic nuclei. So remember diencephalon, all things thalamus, right? Epithalamus, hypothalamus, thalamus, thalamic nuclei, right? Yeah. So we're here on this guy just to kind of remind you where we are. Okay, just a little break. Sensory afferent dorsal, a little reminder there for us. Ventral is motor, sensory is dorsal. Then we can see here, almost immediately after exiting the foramen, those spinal nerves are divided out into three branches. We see the dorsal rami or dorsal ramus, that's the smaller one. Ventral is going to be the larger one. And the meningeal is a tiny branch that re-enters that vertebral canal to innervate the meninges in the blood vessels. The rami communicantes, so they're communicating, okay, branches that communicate, rami, ramus, branch, okay, or arm or branch, okay, so just branches. Rami communicantes, this is the autonomic nerve fibers that join ventral rami in the thoracic region. Good. And you can see here we have our dorsal ramus coming off here, right? So dorsal coming out of here, so we see our cord, yeah. And then our spinal nerve, and then we could see ventral going to the front, dorsal going to the back. You can see a little bit of that sympathetic chain here. Good. Spinal gray matter is regionally specialized. So we see that ventral median fissure, dorsal median sulcus, dividing right to left, right? So dorsal median sulcus, ventral is the bigger one that we look for to orient ourselves because we don't see the DRG here, right? So we're going to then see that this comes all the way to the edge in our picture here. But when we're looking at a real specimen, it's a little bit harder to see that, especially if we're in different sections of the spinal cord and different staining techniques, things like that. So usually I just look for this guy right here for orienting myself up, down, side to side. Okay. Dorsal lateral sulcus, dorsal root center here. And so dorsal lateral sulcus, so info coming in here. Ventral lateral sulcus, ventral rootlets are going to exit through that area. So we see the white matter, the dorsal funiculus, lateral funiculus, ventral funiculus. We see a posterior lateral or the Lissauer's tract coming in. Okay, so it's going to come in. We'll see a picture of that. And then the anterior white commissure. Okay, so our anterior white commissure. Okay, cross over. All right, our Rexed lamina slide here. So gray matter regionally specialized with naming it Rexed lamina. So let's look here on the right-hand side here is where I want to focus in on. So we have Rexed number 1. This area here is 2. Rexed 2 is, we're going to look at all of these, but one that we really want to note, we call it substantia gelatinosa. This is going to be touch pain temperature. Don't worry about writing that down yet. I've got a table a little bit later. So if you look at the order of things here, let's see where we are, right? So A for anterior, right, or ventral. So this is dorsal, because these are our dorsal columns here, right? Fasciculus, cuneatus, and gracilis. So we could see that fasciculus, cuneatus, and gracilis. And then as we come here, so this is dorsal area here, we're going to see this pathway coming up in a minute. We'll go through that in a different slide, but let's look right here real quick. So 1, 2, 3, 4, 5, 6. So when I draw this, I put a little line right here after I draw my spinal cord, and I just go 1 through 6. And I don't draw all those lines. To me, after looking at that for a little while, it kind of looks like that Cat in the Hat hat, right? It's kind of got that shape and those stripes. So we go 1 through 6, okay, and this is going to be the dorsal horn. And then we've got 7 is this area right in here in blue. Okay, we've got that guy right there. And then we have 8, and then 9 is going to be a couple of spots here. Right? And when I look at other resources, there's a couple other spots for 9 as well. Okay? And then 10, if we have a 10, sometimes a 10 is noted, it's right here. So I use that central canal as the 0 for my 10 to remember where 10 is. Okay, so let's look at what this Rexhead lamina means. All right, so why is this named Rexhead, right? So it's Dr. Rexhead. So 1952. So I'm always amazed at the years on this. You would think that we would need more equipment, right? And that the equipment wouldn't have been good enough. So just like right after World War II, they're capable of figuring this stuff out. It's kind of amazing to me. So in 1952, Rexhead devised a system for subdividing the gray matter of a cat's spinal cord into layers or lamina. The same system has since been applied to cords of other mammals, including humans. So we're going to go through this in chart form here. So this is just the narrative form, but I find that kind of amazing that they were able to figure that out that long ago. Okay, so the picture here, just to kind of put it in perspective, again, remember that picture on the left side of your screen here is stained, and it's a myelin-loving stain, so that's why that's darker. The white matter is darker. Okay. Here is the chart from your book. So the chart from the book and then my chart that I made while going through my neurology diplomate program is slightly different. Okay, so this is the book. And you're going to say, hey, which one should we use? Well, you could really use either. The difference is just the one I use has a little extra, and I lined it up a little different. So the book here has laminas over here. Okay, so the lamina here is 1, 2, 3 through 6, 7, 7, 7, 9, 9. Doesn't even mention 8, doesn't mention 10. Okay, so you can see the nucleus is the marginal zone. The name is marginal zone, and it's at all levels. And it's going to have some spinal thalamic tract cells. Number 2 is at all levels. That's substantia gelatinosa. Put a star next to this one here. This is the one that tends to get asked on your boards and that we kind of pay attention to because this is for touch, pain, and temperature. Okay, so modulates transmission of pain and temperature information. So this is what we do for a living, right? Body of posterior horn, this is 3 through 6. This is just sensory. So remember, this is dorsal, okay, posterior dorsal. So the dorsal horn, this is all sensory. 1 through 6 is sensory. Okay, so 1 and 2, they're a little specific with it, and then 3 through 6 is just sensory. Number 7 gets asked as well. So Clark's column is number 7, T1 through L2, and then T1 through L3 is intermedial lateral column, or the IML is what we usually just call that, IML. And then you're going to see the sacral parasympathetic nucleus is going to be lamina number 7 as well. Obviously, that's going to be in the sacrum, so S2, S3, S4. Okay, so Clark's column, Clark's nucleus, same. T1 through L2. Okay, that's number 7. And it's going to be some posterior spinocerebellar tract cells. Okay. IML, that's going to be preganglionic sympathetic neurons. Sympathetics makes sense. Look where it is, T1 through L3. Sacral parasympathetic nucleus, so sacrum, right? S2, S3, S4. So what is this doing? Parasympathetic pelvic viscera. Okay, so parasympathetic pelvic viscera, S2, S3, S4, responsible for bladder, bowel, and genital. Accessory nucleus, medulla through C5. So think about the accessory nerve. So cranial nerve number 11, think accessory nucleus. And this is, number 9 is going to be the alpha motor neurons. So this is going to be the movement. So this is when we think about what movement is associated with what area. So C3, C4, C5 keeps the diaphragm alive, right? So that's going to be to the phrenic nerve. And then we see our accessory nucleus. That's going to be to the accessory nerve, cranial nerve 11, and that is going to be upper traps and SCM, right? So accessory nucleus, accessory nerve, spinal accessory nerve, cranial nerve 11, phrenic, C3, C4, C5, diaphragm. So this is the chart that I made while I was studying for my neurology diplomate program. So I think in this order, okay? So the numbers should be on the left, right? And then the name and then the function. That's how my brain organizes these things, okay? So number 1, posterior marginal, some spinal thalamics, done. 2, substantia gelatinosa, pain and temperature, sympathetics. Okay, so this is going to have a sympathetic component to it. Of course it will, right? So if you have pain coming through, that's going to give a little bit of a sympathetic response as well. 3, 4, 5, and 6, dorsal horn, sensory and fear response as well. Okay, so sensory and fear response, not all just fear response though, so it's just regular sensory as well. 3 7s, 7, 7, 7, Clark's column, sometimes called nucleus dorsalis. Okay, so dorsal spinal cerebellar and the dorsal columns. So dorsal spinal cerebellar, so spinal cerebellar, what's it going to do? It's going to help us with balance. Dorsal columns, that's fasciculus cuneatus and gracilis. That's going to be our unconscious proprioception, 2-point discrimination. That's going to be vibration sense. So that is from our extremities. Remember, so fasciculus, gracilis, lower extremity, fasciculus cuneatus, upper extremity. And we have that whole tracks lesson in a different lesson, remember. IML, preganglionic sympathetics, inhibited by our frontal lobe, which is going to inhibit flexors. So frontal lobe, remember, is our executive function. It's where our personality lives. It's who we are, right? And that will help to inhibit this kind of pre-programmed stress response as well. The other 7, that's sacral parasympathetics, obviously is going to be in the sacrum, and that's the pelvic viscera. Number 8, motor interneurons. This is going to be some of our reticulospinal fibers and vestibulospinal fibers. Number 9, accessory alpha motor neurons, SCM and upper trap, accessory nerve. Number 9 again, so we have 9, 9, and 9 here. Phrenic alpha motor neurons, diaphragm, C3, C4, C5. And number 9, nucleus of Onuf. This is going to be in the sacrum, and this is bladder control. So when we have a child that has fallen and subluxated their sacrum and they start wetting the bed again at night, right? First thing we rule out is sexual trauma to the kid. That's the big red flag when a kid starts wetting their bed at night. But if we know that maybe they fell off their bike and they're safe otherwise, then we go towards the sacrum and say, okay, what happened here? And then when we adjust it, why does their bladder continence get better? Why do they stop wetting the bed at night? And then the parent says, well, it was a coincidence or it's magic or whatever. And you're like, nope, it's the nucleus of Onuf. And we know that this is happening at the cord right here. So again, our picture here after my explanation there. So let's look here. When I draw this, okay, so I'll draw my cord, right? Motorcycles in the background, can't help it, Daytona Beach. If I stopped every time they rolled by, I'd never get any work done. 1 through 6, right here, okay, so we know that these are the dorsal columns right here. So this is dorsal, so that's the dorsal horn I just outlined there. 1 through 6, sensory, right? And then up top here, okay, all of this is 7, okay, 7, and then 9 has some circles here, okay? And then I add in a 10, and if you need a 10, it is just where things cross over, and that's kind of obvious that that's where the comma shore is. So let's take another look at this picture. So we looked at the picture on the right, that's the Rexed lamina and the numbering of the Rexed lamina. And then the left side of this is, we're going to go through this, so that 1 through 4. Now the thing to note is that both of these are symmetrical, and this is on both sides. So it's not just one or the other. It just would be way too busy of a picture to show it on both sides. Okay, so what are we looking at here? We're looking at a section that's representing C8. Okay, so this is that C8 section here. You would be taking a look at that area in between C7 and T1. So Rexed on the right, and then the cells and their connections are on the left. And we're looking at large diameter, heavily myelinated afferents. So when we look at these numbers, okay, so number 1 enters medially through the posterior funiculus. Okay, so posterior funiculus or the dorsal columns. Okay, so dorsal columns, posterior funiculus. Whereas the small diameter afferents, or that number 2 line coming in, are entering laterally near substantia gelatinosa, or that Rexed number 2. This corresponds to the way tactile and proprioceptive or position sense information is processed relative to pain and temperature. So these afferents then contact the interneurons at 3, and in some cases the motor neurons at 4. If say it's a reflex right there, right? We would just go straight on through the cord. There would also be the signal up though, that's going to then be that's going to cross over and then become that spinothalamic tract for touch, pain, and temperature, if that's the information that's coming in. And you could see up at the top there the pain temperature afferent coming in, and then you can see how that is Lissauer's tract. So you might see that word. I wanted to make sure I found a picture that had Lissauer's tract in there. So the Lissauer's tract and then substantia gelatinosa. So really it's just naming roads, right? So these are roads, pathways in. This little stretch of the road is called Lissauer's tract, and then we see the cell body at the substantia gelatinosa. And then you can see here in green how it crosses over and it says 2 STT. STT is spinothalamic tract, right? Touch, pain, temperature. This is just another picture for you, kind of see what we're looking at here. You can see that kind of dorsal rootlet there, that SG being substantia gelatinosa area. You don't have to label this or memorize it. It's just a cool looking picture, give you a little perspective. Different cross sections are going to look different at these different levels. So they do different things, right? So kind of a neat thing to kind of look at. So C3, C5, C8, T5 over on the left. Then you can see T10, L2, L5, S4. And look at the difference between the gray matter to white matter ratio. I think that's kind of neat looking there. Okay. So just a couple cool pictures, give you some perspective. So important to note, we want to look at this inner area here, right? So about here is where 6 would be, and then I just go 1 through 5 here, okay, 10. And then this area, a lot of that area as well, is 7. And then I put a couple of 9s in here. IML, Clark's column, nucleus vonif, okay, and that's pretty much how we're going to break that down. What we want to remember about this gray area or the Rexed lamina, so all of this, these are the cell bodies, remember. So the information is going to come in here, dorsal root ganglion, sensory, information coming in. So we had our Lissauer's guy here, right? So information coming in, touch, pain, temperature, synapsing at substantia gelatinosa or Rexed 2, and then coming over, just crossing through, okay? And then he is going to come right through, well, I should have done it on the other side here because you can see here's spinothalamic tract and here's spinothalamic tract. Okay, but I'll just continue my line. So come right through here, okay, and go up. So we can call that the ALS or anterolateral system or spinothalamic. So this inside area here of note, cell bodies for the axons that are the tracks or the white matter. So that's how they relate to each other. And we get into, again, tracks in a different lesson solely on tracks. So you can kind of watch that one over and over and over again until you get tracks down, because tracks show up on your boards pretty heavy. Okay, so for the other part of our lesson today, we wanted to look a little bit at the blood vessels. So when we did our circle of Willis, I have a tendency of calling all of the blood vessels in the brain the circle of Willis. It's not, it's just that pink part. So just kind of bear with me on that one. And just kind of lump them all together. But we have our little guy here, right? So we have the little face and the little antenna. Okay, these guys here, anterior cerebral, the little guy in the middle, anterior communicating. Okay, so we're coming down. We've got PCOM here, posterior communicating. We had, well, I'm trying to go here. There we go. Basilar, vertebral. Okay, and then we can see this guy right here in the middle. That's the anterior spinal artery. So this is going to be right there, anterior spinal artery. And then this little guy here goes around to the back and is the posterior spinal artery. That's where we are right here. Okay, so we could see vertebrals coming down right here, right? We could see vertebrals. And then this is basilar. So flip it around. Okay, so you want to flip it around. So basilar is here. Basilar is here. Basilar is here. Okay, so in this picture, that's what they're doing. Okay, so we have our basilar artery, we have our vertebral artery, and then we could see this anterior spinal artery. So this is in the front, right? So let's look here. Are we in the front? Yep, because we see that ventral median sulcus, that bigger, or fissure, sorry, bigger, deeper groove right there than here. So there's our dorsal columns back here, and then check out where our DRG is. Okay, so dorsal. A couple of ways that we can orient where we are in space. Okay? And the blood vessels now too, but we're just learning those right now. So now we can use that as a reference as well. So we can see basilar, we see vertebral, we see anterior, and that's going to give us blood supply to that anterior part of the spinal cord. So right through here, okay, so again, orient to ourselves, we can see the DRG back here. Okay, so posterior spinal artery, and then we have our aorta right here. Okay, so that's going to be in front of the vertebral bodies. Okay, and in between there, you're going to then learn about the lymph system that aorta is kind of beating against the lumbar and thoracic vertebra and creating movement for the lymph via the thoracic duct and the cisterna chyli, but we're not there yet. But that's where the aorta is in comparison to the spine here. So right here, let's take a look here. Where'd we go? Okay, great. All right, so anterior spinal artery, branch off of those vertebral arteries. Okay, so anterior vertebral. So we could see that guy right here. Okay, so anterior, coming off of that vertebral. We saw that. Posterior branches off of pica, posterior inferior cerebellar artery. Radicular arteries branch off of cervical, intercostal, and lumbar arteries, and the largest is the artery of Adamkowitz. What? Artery of Adamkowitz, right? This guy. So we can see the artery of Adamkowitz right here. Just the largest guy coming off of that. Okay. This one's a nice picture, I think, because you can see this here showing us the area affected by an infarct or lack of blood supply to the anterior spinal artery. So note all of that pink area. And again, remember that blue and red, those are bilateral and symmetrical. So it's on both sides. So we're going to see some massive deficits when there is an issue with our anterior spinal artery. So some dysfunctions, we're going to go through this. So it's pages 267 and into 269. So if you're following along with your book, that's where we're at. This picture not in your book, but I just liked it because it kind of puts it all together for us. So we have central cord. Okay, so looking at all the things in the center here. So taking what you know about tracts and what you know about the Rexhead lamina, what's going to happen if there's a central cord syndrome, okay, deficit in this area. Anterior cord, so what if there's a problem where this pink area is? What tracts are going to be involved? What Rexhead lamina? And then Brown-Séquard's. So we looked at Brown-Séquard's a little bit in the tracts lesson, so we're going to kind of bring that back in as well. So that's one-sided. Let's look at upper motor neurons versus lower motor neuron lesions as well. Okay, so upper motor neurons versus lower motor neurons. So upper motor neurons, when we take the reflex hammer and we see a lot of movement, okay, or a clonus, or the body's not getting the message to stop. So it's getting the message to go, but not stop. It's the run, Forrest, run, but not the stop, Forrest, stop, right? So we'll see an upper motor neuron lesion, contralateral lesion occurs above the pyramidal decussation. So remember our pyramids and our olives of the medulla. So we see that contralateral, or that opposite side decussation crossover. Okay. Ipsilateral upper motor neuron lesions, if the lesion's occurring below the pyramidal decussation. So upper motor neuron, problem with something, usually brain. Okay, so upper motor, spastic paresis, kind of stuck, right? So think of someone that's stuck in flexion from a stroke. Okay, so spastic paresis, not necessarily atrophy until way late stages. We'll see a little bit of atrophy only because they're not using it appropriately, but because they're stuck in this kind of spastic, we still see muscle tone. It's just not healthy muscle tone. Hyperreflexia, or that clonus. Okay, no fasciculations. And then we see a positive pathological reflex, or a Babinski. So when you scrape the bottom of the foot and we see that big toe and maybe the other guys splay up a little bit. So remember, when you scrape the bottom of the foot with your reflex hammer, nothing should happen, or maybe a little curl or flexion in. The way that I remembered this was, if you're coming at me to hurt me, to punch me, right, and I am neurologically normal, I'm going to defend into this flexion response, right? We're pre-programmed into this flexion response. Think of the rubrospinal tract. Think of everything that is like fetal position, right? If we're not neurologically normal, right, and you offend my body here with that scrape at the bottom of the foot, right, and it opens up into extension, that would be the equivalent of if you were coming at me and about to punch me and I leaned in and extended into that punch. Neurologically, that wouldn't make sense. That's not protective. So that's not a pre-programmed stress response for protection. That's telling us that there's something seriously wrong in the upper motor neuron region. And then we will not there's no superficial reflex. Okay. Lower motor neuron lesions are going to be ipsilateral, and this is going to be a flaccid paralysis, so no movement. So therefore, we're going to see atrophy because you can't move it. And then you see a loss of deep tendon reflex. So you hit the knee, right? So instead of getting your good reflex, that was my knee, right? Analogy for the knee there. Mind learning. So without getting a response, first you think use your error and you keep whacking away at them, right? And then you're like, all right, maybe they don't have a reflex. So that's why that H reflex is a good idea, right? So loss of deep tendon reflex, or lowered, we'll see fasciculations, or these kind of wiggly, kind of twitchy looking movements, and they're not going to have a Babinski. Okay, they're not going to have that flare or extension of the foot when you scrape. Okay, and then we do see superficial reflex. Okay, and then my question to you would be, which one do you think subluxation would be associated with? We see subluxation associated more with lower motor neuron lesions. Okay, so upper motor neuron lesions, that's going to be more of a stroke. I really hope that that wouldn't be associated with a subluxation. But lower motor neuron lesions, when we do a reflex at the knee with the reflex hammer, and then you adjust the appropriate segment, sometimes check it again with your post-check. Sometimes it's better. Sometimes it cleared out. Sometimes it was just a subluxation that was causing a little miscommunication, and that was just that simple. Looking at an important distinction between upper motor neuron lesions and lower motor neuron lesions as evidenced by the face. So let's look at Bell's palsy, or a cranial nerve 7 lesion or facial nerve lesion, versus a stroke or a supranuclear lesion. So supranuclear, that could be stroke, that could be a tumor, that could be those are our main ones. We're looking mostly for stroke. So upper motor neuron lesion, stroke; lower motor neuron lesion, Bell's palsy. Upper motor neuron lesion, corticobulbar tract is going to be involved. So remember, that's contralateral to the body side. And then the forehead is innervated here. So what we say, the term we use is that a stroke is forehead sparing. So note the difference in the green versus the purple. Okay, so green versus purple there. So we're knocking out the main one up at the top on the contralateral side. So if you look at this area right here, supranuclear lesion here, so stroke, okay, stroke happens here, knocks this out. We're going to see this crossover here, right? We can see the crossover, and then we can see that this is eyebrow sparing. This purple one here, you can see some same side fibers. This guy's still innervating here. Okay, so eyebrow sparing, can they still lift their eyebrows? Lower motor neuron lesion, you're going to see here is the lesion. Okay, the nucleus of the facial nerve, cranial nerve 7. So remember our rule of 4s, right? So we do our 12 cranial nerves and then group them in 4s. Okay, so cranial nerves 1, 2, 3, and 4 are going to be midbrain and above. 1 and 2 not in the midbrain, right? So midbrain and above. And then 5, 6, 7, 8 is going to be in the pons. And then 9, 10, 11, 12 is going to be coming from the medulla. Okay, so we can see where this number 7 here is coming from that pons area. And then we could see the lesion in the facial nerve right here, and it's going to knock out both purple and green at this area here. Okay, so we're going to see the whole side of the face droop, and it's ipsilateral. Facial nerve, ipsilateral, entire face is affected. Now this is the differential. Can they move their eyebrows? Okay. To me, this is academic only. If they have not been to the hospital, if this is a new onset, acute sudden onset, I'm sending them out to the hospital. I'm not going to determine whether or not they're having a stroke versus whether or not they can use their eyebrows. I know that there are way too many zebras out there in the world, right? So when we work with medicine, we go for we have a saying, if you hear hoof prints, think horses, not zebras, right? But I'm not betting somebody's life on the fact that this anatomy is intact in them, right? So we see too many anomalies out there. We see a cervical rib, we see an L6 vertebra, we see different innervation for different people. Is it common? No. But am I betting their life on it? No. Right? Also, in this day and age, especially depending on where you're living, they might not be able to raise their eyebrows for other reasons. Anybody want to come up with an idea on another reason why they might be not able to raise their eyebrows? Yeah, Botox, right? So maybe they have Botoxed their forehead for cosmetic, or maybe they're a migraine patient and they are getting medically treated with Botox. Okay, so send this person out. Okay, this is an academic exercise So other practitioners can disagree with me, but this is the way that I practice. And so I'm going to err on the side of caution. I don't want to have to be responsible for making the wrong call here and somebody's life depending on it. Upper motor neuron lesions, superficial reflexes. Loss indicates an upper motor neuron lesion. Okay, so abdominal, stroke the skin of the abdomen and the umbilicus should deviate towards stimulation. This doesn't always work on most people that I've done this on, so don't bet on this one either. Cremasteric, don't do this one. Okay, so stroke medial upper thigh and testes pull upwards on that side. That's not for us to do. This would be in a hospital setting. Pathological reflexes, Babinski. This is the one we do. Babinski's and Hoffman's. This is us all day. We should be doing this on every single patient. Babinski's, stroke the lateral aspect of the plantar foot. So stroke the bottom of their foot from heel all the way up. So if you were to, you know when they do prints on a baby's foot, the little ink print, so where that ink would hit is where you're going to scrape up the bottom of the foot. The big toe should not flare upwards. If it does, again, I just explained what that meant a few slides back. It's an upper motor neuron lesion. So normally, neurologically intact people are going to go into flexion of the body part or retraction of the body part if it's challenged or hurt. It's not normal to go into extension, so we can get hurt more. Hoffman's is the equivalence of the Babinski, but on the upper extremity. So we're going to see more Babinskis than Hoffman's. Hoffman's are going to be a rare presentation. Okay, so lower extremity upper motor neuron lesion is going to be more evidence than a Hoffman's. So it's a downward flick of the middle fingernail. So you just kind of flick the nail, and then if it's positive, the thumb and index finger will flare. Brown-Séquard's syndrome. It's a rare neurological condition. It's rare, but we talk about it all the time in academia because it's a really great way to check in to see that you know your anatomy and to study the anatomy. So it's a little bit of a game, a mind game here to check in and see, do we know what all of these different tracks are doing, and do we know who's crossing over and who's not? So Brown-Séquard, rare neurological condition characterized by a lesion of the spinal cord, which results in weakness or paralysis, or hemiparaplegia, hemi being half, so right or left side, not half as in lower extremity, of the body, and a loss of sensation, so hemianesthesia on the opposite side. Brown-Séquard syndrome may be caused by a spinal cord tumor, trauma, such as puncture wound to the neck or back, shrapnel, ischemia, which is lack of blood supply, or infection, inflammatory disease, tuberculosis, MS could cause a couple of lesions in this kind of small area as well. So we see this lateral hemisection, and then look at that orange area here, right? So it's just an academic game of, okay, one side is taken out. What are those symptoms going to be? What's going to be same side? What's going to be opposite side? Okay, so we see dorsal columns being taken out here, so fasciculus gracilis and cuneatus, and then we can see lateral corticospinal tract, lateral spinal thalamic tract. So damage to this area would affect these tracts, causing same side spastic paralysis and loss of fine touch and proprioception. So spastic paralysis, what tract of those three tracts would cause spastic paralysis? Which is the only descending tract. So it's going to go out to the muscles. Yes, corticospinal tract. Good job. And loss of fine touch and proprioception. And contralateral loss of pain and temperature. So fine touch, proprioception. Yes, dorsal columns. Touch, pain, temperature, spinal thalamic. Excellent. Another one here for you is kind of bright. Okay, so lateral hemisection here, so ipsilateral loss of vibration, 2-point discrimination, proprioception. That's our dorsal columns. Contralateral loss of pain and temperature. And the note here is that it would be 1 to 2 levels below the injury because of the way that that corticospinal tract descends. Ipsilateral spastic paralysis, hyperreflexia, clonus, Babinski, below the injury. Yep, corticospinal. Did I say corticospinal for green or spinal thalamic? So I think I said, let's make sure I said this right. So spinal thalamic tract here, dorsal columns here. That kind of looks like a P, and that works too. Posterior columns, dorsal columns, right? And then ipsilateral spastic paralysis, corticospinal. Make sure that's nice and clear for you guys. Anterior spinal artery thrombosis. So we looked at this a little bit as well, but let's go through it again. Anterior spinal artery supplies anterior 2/3 of the spinal cord. Bilateral loss of pain and temperature below the level of the injury. Dorsal columns can remain intact. We see bilateral flaccid paralysis or no movement, okay, so just kind of droopy and atrophied, and loss of reflex at the level of injury. Spastic paraplegia below the level of injury. So what tracts are affected? Okay, so what tracts? And then look on over at the right there. Okay. So spinal thalamic and corticospinal tracts. Okay, so spinal thalamic and corticospinal tracts are the tracts affected. Transection of the cord. So we see a loss of sensation and motor control below the level of the injury. So this would be somebody in a car accident or like Christopher Reeves in the horse accident. So we're going to see loss of bowel and bladder control. And it's really, it's just dependent upon what level of the cord was injured, and then everything below that is knocked out. Okay, so we're not going to have function of everything below that, so it depends on what level. Okay, so we're going to see upper motor neuron lesion signs show up after a couple of weeks, so not right away necessarily. Okay. So then we would see that Babinski show up. We might see hyperreflexia, clonus, spastic limbs, spasms of the leg flexor muscles. So again, dependent upon where that lesion is, where the cut is, where it's transected. So if it happens at C3, C4, C5 area, that's going to affect breathing. And so lower down, the further down, the better with this one. So spinal cord trauma, localized injury to the spinal cord or its roots leading to the functional losses. So paresthesias caused by damage to the dorsal roots or sensory tracts. So we see a sensory functional loss here. Paralysis would be damage to the ventral roots or the ventral horn cells. So we would see the motor function damaged here. So two types of paralysis, flaccid and spastic. Flaccid, you're not going to see any muscle tone. Spastic, you're going to see extreme muscle tone. Both, you still can't move. Okay, so stuck in a spastic condition or stuck in a flaccid condition. Flaccid, severe damage to ventral or ventral horn cells. Impulses do not reach the muscles at all. There's no voluntary or involuntary control of the muscles, and we see muscle atrophy. So the muscles are not firing off, so they're going to become extremely weak and smaller. Spastic paralysis, damage to the upper motor neurons of primary motor cortex. Spinal neurons remain intact. Muscles are stimulated by reflex activity. So no voluntary control of muscles. Muscles often shorten permanently. So they're stuck in that reflex. So a couple of terminologies here. So that transection or that cross-section in the spinal cord at any level results in total motor and sensory loss inferior. So paraplegia. Paraplegia would be between levels T1 and L1. Quadriplegia would be a transection in the cervical region. Spinal shock is a transient period of functional loss causal to the lesion, and they might recover. Dorsal root lesions, pain and paresthesias, numbness, tingling in that dermatome, loss of sensation in that dermatome, hypotonia or decreased resistance to passive movement. So they're really just kind of dead sleepy weight, right, when moving them around. And we see a loss of deep tendon reflex. Chapter 10 has this table here for referred pain patterns and radiculopathy, so that R, so our MLP, QRSTA, so radiating and referring pain. So referring pain is the picture on the right, and that's the one where I look to the meridians instead of looking to this. And then the radiating pain would be the picture on the left, so that dermatome. Okay, so if the diaphragm were to be damaged, you might feel it in the C3, C4 dermatome. Heart, T1, T4, mainly on the left. Stomach dermatome is T6 to T9. Gallbladder, T7 to T8. Duodenum, T9, T10. Appendix, T10 on the right. Reproductive organs, T10 through T12. Kidney and ureters, L1, L2. So if they're having these issues, so if you have a gallbladder patient, right, I'm checking T7, T8 all the time, checking every aspect of their body all the time, right? So we're going to adjust what needs to be adjusted, but just to let you know there's a rhyme and a reason to it. What's a syringomyelia? So syringo, let's work this word out, right? So syringo, syringe. Okay, so how do you fill up a syringe, right? So I used to work as a nurse's assistant way a long time ago, right? And watching the nurse fill up a syringe for some insulin. So they push the air in and into whatever that vial is of what they're getting out. So insulin, right? So they push a little bit of air in there and then they pull out the fluid, and then that syringe, okay, so that negative pressure of pulling on that syringe is going to pull the fluid out. And then we're going to see that same phenomenon happening in the cord at the central canal. Okay. Myelia, so myelo here is going to be spinal cord. Sometimes myelo is going to be bone marrow, so it's that, that soft substance deep within the bone. Okay. Spinal thalamic tract crosses over at the spinal level. Dorsal columns does not cross over until the medulla. And then we see this lateral touch pain temperature of the bilateral limbs because of spinal thalamic, and a cape-like sensory loss of pain and temperature that occurs in a small central cord lesion in the cervical and upper thoracic cord. Find me somebody that did not have this question on their boards at some point or another throughout their board-taking career. Okay, so cape-like sensory loss, you see cape-like, you're going for syringomyelia. Okay, so that damage in the middle, and then it can expand outwards. So here's our picture of syringomyelia, okay, the syringe here, and the fluid-filled cyst in the central canal. Destruction of gray matter surrounding that central canal, so it's going to expand out from the center there, and what's in the center? It's that gray matter, so we're going to see that first hurt there. So let's look here with the red marker. So front, back, okay. Spinal cord here is in this dark gray, right? So dark gray, we can see fluid around it as white. Here's our cerebellum with the little tonsils there. It's not going down that far, so foramen magnum. You can see right there. Right there. And then coming down here in the cord, let's go for yellow now. Okay, so this dark area here is the cord. What is this white spot here? That's the syringomyelia. So what happened here is a negative pressure, right? So the idea with negative pressure is this is how we breathe, right? So our diaphragm, okay, has nothing to do with this syringomyelia. It's just negative pressure is what I'm explaining now. So the diaphragm, when we breathe, is going to contract on our inhale, and it's going to flatten out and kind of pull down into our abdomen, and that's going to open up the space for the lungs to open, kind of pull down, expand, and then air is going to rush in to fill that space. So think of if you ever wore a one-piece bathing suit, and you're swimming and you pull, this is what we did as kids, right? So you pull on the belly part of the bathing suit and you keep pulling, it's kind of suctiony, and then all of a sudden, boop, it expands with air, right? And then you've got this big air belly, which, you know, that's what you do when you're kids. That is negative pressure. Okay, so that pressure, and then whoop, something rushes in there. Okay, so the air in the bathing suit or here, pressure, and then what's going to rush into that center area, that's going to be cerebrospinal fluid. Now, why would this happen? So the main thing for just regular normal occurrences of this is going to be cord tethering, right? So we lose the cervical curve, we lose the lumbar curve, and we sit all day and we are molding our spine into a position that is not healthy for it. And this kind of tethering of the cord, this text neck happening. So too much pressure, overload, and then boom, it's going to cavitate with that cerebrospinal fluid. So a lot of times with this, we'll see an Arnold-Chiari malformation occur as well. So this CTE or cerebellar tonsillar ectopia will happen as well with the syringomyelia in order as a response really to the pressure. Another one here for you. So spinal thalamic tract decussates at the spinal level here. Dorsal column does not. Loss of pain and temperature in the bilateral limbs. And cape-like distribution. Those are the things we're looking for on our test questions here. But of note, when we're with our patient and looking, we're looking for that area. They've already highlighted it in purple there for you. So again, we're looking for this foramen magnum line here. I went up a little high there, so you would normally have a ruler, and that's looking pretty good for what's going on with this patient, so not too bad at the top there. But this fluid here, so colored area defines the syringomyelia or syringoma. So oma is tumor or mass of. Okay. Arnold-Chiari goes with this, so you could see this CTE or cerebellar tonsillar ectopia. So you take your line from here to here, and the brain should all be above that, right? So where are we? We see medulla here. We could see the circle of the pons. Okay, so pons area is right there. Midbrain is here. Superior colliculus is here. Inferior. This makes this the third ventricle up here. Aqueduct, cerebral aqueduct right here. Fourth ventricle, cerebellum. Tonsils are lower down, so I'm going to erase that so you can see it now. Right, so what are we looking for? We are looking for this line right here, and that this area right here has obviously herniated down. Now, make sure when your patient has an MRI, make sure you look at it. Okay? So sometimes, I don't know if it was just the area that I was in and the radiologist kept missing it, or they thought it was insignificant, or what was going on. But I found a lot of CTEs on my patients that didn't show up in the report. So always get the disc of the images, or get them emailed to you, or however they're doing it. So you can see it on this side here as well. Okay, so not as clear, but it's still here. I'll use yellow. Okay, so right here, and then check the line. Okay, so foramen magnum right here. That's not even a straight line, and it's still dipping way down. So what do we do, right? So what do we do about it? So one of the things that we can do is try and help them get their cervical curve back. Okay, so that pressure on the cord, okay, creating that CTE, pulling down the tonsils of the cerebellum, and then pressure, boom, popping open that central canal and creating that syringomyelia. What can we do, right? We want to recreate the cervical curve. How do we create the cervical curve in the first place? So remember development, right? So babies are not born with a cervical curve. We're born kind of C-shaped, right? And then the cervical and lordotic curve develop. How do they develop? Tummy time, right? So are we going to call it tummy time to the adult? You might. Okay? I'm going to call it cobra pose for our patients, and I'm going to show them how to do a nice, easy yoga routine. Okay? So we're going to do cat, cow, child's pose all day for this patient, right? So cat in the flexion and cow in the extension, and then child's pose for traction. So flexion, extension, traction. So that is extremely helpful when working with our upper cross, lower cross syndrome patients, is to get them to get those curves back, because what happened, right? So we sit all day and the anterior shoulders are going to get tight, and we're going to get that forward head posture. We're going to lose the proper curvature of our lumbar spine as well, unless we're sitting in perfect posture, and who does that all day, right? So looking here at our upper cross syndromes, we always want to bring everything back to upper cross, lower cross from this kind of functional standpoint, right? So even neurologically, like what's going on, right? So this is the idea of the upper flexors, specifically like rubrospinal tract, that red nucleus, dictating that when we're neurologically challenged, that we go into that fetal position, especially with the upper extremities. So let's take a look at this now with the knowledge that we have now. I'll use my yellow marker, upper cross syndrome. So what's going on with this guy here, right? So what's inhibited? His deep cervical flexors. So think about jutting your chin out and just kind of resting in on that. And what's that doing to the suboccipitals and the neck alignment? Okay? Inhibited here. So we're not using that serratus anterior, the lower traps. So we're kind of rounding through the spine. What's facilitated or tight? Okay, so these are tight. These are firing off inappropriately in order to compensate, right? And kind of flex forward and protect in that flexion protection. Your SCM, that sternocleidomastoid. So we're going to see that as tight, usually one side or the other, and that's going to further create rotational misalignments as well. Rotational and lateral misalignments. And then pecs, right? So pec minor, feel your pec minor, go to your coracoid process, right? And then move down the rib into the ribs and feel that pec minor. Who doesn't have a tight pec minor after sitting all day, right? And then of course pec major as well. And then facilitated upper traps and levator scapula. Feel your upper traps. Are those happy? Probably not. And so those are probably super tight. So that's what facilitated means. And so feel your upper traps. That's exactly what that means. And then lower cross syndrome goes with this, right? So inhibited would be our abs and our glutes. Okay, so inhibited is our abs and our glutes. Okay, so nobody's walking around saying my abs of steel are really a problem, right? Or my glutes of steel or buns of steel, that's what it was, are really a problem. No. Okay, so no, these are what's going to help stabilize us. I did have a parkour instructor as a patient, and they had the opposite problem, but that was kind of rare, right? So facilitated would be rectus femoris and iliopsoas, sitting all day, our hip flexor, that iliopsoas, and then the continuation of that muscle train into rectus femoris. So that's tight on people. It's going to pull us out of alignment. And then facilitated at the top, right? So who is trying to combat this when you try and stand up? So if you have a tight hip flexor and you're not activating glute max, the proper hip extensor, who's going to get you to stand up and stand upright? It's the thoracolumbar extensors. So when your patient comes in and says, I have back pain, and they point to their back, they're probably pointing at this. These are overtaxed, just like on the upper cross side, our upper traps are tight, right? Let's talk about reflexes now. So what is a reflex? Here's our definition. Certain specified afferent inputs cause stereotyped motor outputs. This is called a reflex. Our example here is the familiar knee jerk reflex. So you hit the patient's patellar tendon here with the reflex hammer, and their leg kicks out. So that's our first thought usually when we talk about reflexes, but we have more reflexes than just that. This is a commonly tested deep tendon reflex chart here. So looking here at this blue chart, you can see the reflex over on the left, so bicep brachii. Principal cord segment is C5. So when you know that the bicep brachii is innervated by C5, C6, it gets a little confusing, but go for C5 as the principal cord segment, the main one. Okay? Peripheral nerve here being tested is going to be musculocutaneous nerve. Brachioradialis muscle. Easy, right? That's going to be C6. That's the radial nerve. Tricep, that's C7, radial nerve as well. Knee jerk, or the patella reflex, the one that we usually think of when we think of deep tendon reflexes, that's going to be testing the quadriceps femoris, or the quads, and that's L4. L4, kick the door, right? So principal cord segment, L4. Peripheral nerve is the femoral nerve. Femoral front, remember. So when we go through our leg muscles, femoral's in the front. Lateral femoral cutaneous nerve is the lateral femoral skin nerve, right? Obturator is internal. Sciatic is posterior leg, so femoral front, okay? Quadriceps femoris. Ankle jerk, or the Achilles reflex, that's going to be testing gastroc and soleus. It's going to be S1, so tibial nerve, S1 tibial. So the next couple of slides, you've seen this format before. It's going to go in a numbered order. This is the main one here. So we're going to kind of take a look at this and then flip right on through and take it one by one. So looking at this overall picture here, what's going on when stretch activates those muscle spindles. Okay, so initial stimulus, muscle stretch coming from here. You could see this here. Looks familiar from earlier slides, chapter 9, that muscle spindle, and then going up and into the, not as easy as it looks to navigate this thing. Okay, so going up and into the cord, okay, making a little stop here at the DRG, dorsal root ganglion. Okay, so let's go ahead and get started. Number 1, when stretch activates muscle spindles, the associated sensory neuron is in blue here. It transmits afferent impulses at higher frequency to the spinal cord. So it's coming on into the spinal cord. Number 2, the sensory neurons synapse directly with alpha motor neurons in red there. So alpha motor neurons, what Rexhead lamina is associated with alpha motor neurons? 9, very good, alpha motor neurons, 9, which excite extrafusal fibers of the stretched muscle. Sensory fibers also synapse with interneurons. You can see that little interneuron in green. I'll highlight it to make sure you guys can see where we're at. So, see that guy right there? Yeah, little green guy. That inhibit motor neurons in purple. You can see where the purple one is coming up right from that interneuron there, that guy. In purple, controlling our antagonist muscle. So in order for that bicep to fire off, right, so this bicep area here, right, to fire off and actually get flexion movement, right, the tricep, or its antagonist, has to get a message as well to relax, as we say with little air quotes over it. It's really an eccentric contraction. So if it totally relaxed, we would have uncontrolled, unopposed movement, and that would jam joints and cause injury. So it's more of an elongation or eccentric contraction that's going to control that movement so it doesn't hurt the joint. Number 3, efferent, so motor efferent, okay? So efferent impulses of alpha motor neurons cause the stretched muscle to contract, which resists or reverses the stretch. Okay, so stretch activating the muscle spindle. Okay, so sensory neuron coming in. We see this interneuron then controlling antagonistic muscles, and then efferent impulses of the alpha motor neuron causing the stretch muscle to contract, so it resists or reverses the stretch. We don't want to overstretch. Okay, so the body's getting a signal here that there is an overstretch and it wants to lock down this muscle. This is an important key component of understanding chiropractic and how we get subluxated and how we get subluxated out of alignment. Something overstretches, the cord sends a lockdown signal saying, hey, I don't want to tear, shut it down, no more movement at that joint, but the joint is fixated out of proper alignment. 3B, efferent impulses of alpha motor neurons to antagonistic muscles are reduced, and we see this reciprocal inhibition. So the same rules apply here. This is just the overview, so you can pause and look at this if you like as well, but we're going to go right on into number 1 in a second here, but we're just going to follow this pathway here. So muscle spindle, and then a little stop here at the DRG, and then coming on in. Okay. Number 1, tapping the patellar ligament or tendon, either one. Stretches the quadriceps and excites its muscle spindles. Afferent impulses in blue travel to the spinal cord where synapses occur with motor neurons and interneurons. Number 3A, so you could see this right here, this pink guy coming here. Okay, so pink guy, 3A, okay, coming in. Motor neurons in red send activating impulses to the quadriceps, causing it to contract, and that extends the knee. 3B, so at the same time here, the interneuron in green makes inhibitory synapses with the ventral horn neurons in purple that prevent the antagonistic muscle or the hamstring from resisting the contraction of the quadriceps. So our agonist and antagonistic have to work together, and the cord is coordinating that. Okay, so in order for our movement to occur, we need an agonist to get the go signal and the antagonist to get the no-go signal. The tendon reflex. So we see polysynaptic reflexes, so poly just meaning many, helps prevent damage due to excessive stretch. So remember, the signal is going to come into the cord saying, I am overstretched, lock it down, I don't want to tear. That's what this whole signal is saying. Okay, so it's important for a smooth onset and termination of muscle contraction. And then a nice little chart over here as well. So we already saw a chart, so I'm not going to read it out to you because I already read the other one out, but this might help you study a little bit if you pause and kind of hang out with that and kind of quiz yourself back and forth. Just a little bit different of a format. So the tendon reflex produces muscle relaxation or lengthening in response to tension. And contraction or passive stretch activates our tendon reflex. Afferent impulses transmitted to the cord and contracting muscle relaxes. Antagonist contracts. That was our reciprocal activation. Information is also going to be going up to the cerebellum. So we've got this stuff that we just saw happening in the cord. There's also going to be information going up, specifically spinal cerebellar tract, into the cerebellum, and that's going to adjust muscle tension and keep us coordinated while we're doing this and make small corrections throughout. Another schematic here. I really like these pictures. It really breaks it down quite nicely. So we could see here, number 1 is starting off with a quadriceps strongly contracting. Okay, so quads strongly contract, and the tendon organs are activated. Number 2, afferent fibers synapse with the interneurons in the spinal cord. Nothing new there. Number 3A, efferent impulses to muscle with stretched tendon are dampened and the muscle relaxes and reduces the tension. 3B, same time, efferent impulses to antagonistic muscle cause it to contract. Let's look here at the flexor and cross extensor reflexes. So the Heisman is how I kind of remember this one here. So Heisman Trophy over there, that kind of football player stance. So that's a really great example of this flexor cross extensor reflex. So it's that painful withdrawal. So you step on something and you need to jump off of that really quick, right? So we're going to flex one leg as our football player is doing, right? So on the picture on the right, our football player is flexing the left leg. He's not stepping on anything painful, but you can see where this would work, right? So he'd be jumping off of that, and then the right leg has to go into an extension in order for him to not fall over. So one leg has to jump into extension and one leg has to jump into flexion in order to withdraw from whatever that problem is. Okay, so it's initiated by a painful stimulus, causes automatic withdrawal of the threatened body part, ipsilateral, so it's same side, and polysynaptic, multiple synapses. It's protective and obviously important. The brain can override it. So like a finger stick for a blood test. Maybe some of us can override that, maybe not, right? That glaucoma puff of air in the eye test, I don't know anybody that can override that one though, right? Because that's right into your eye. So it's not really gonna hit the old flexor one, kinda, right? Makes you jump. Anyways. Flexor, crossed extensor, giving a good example there is our football player. Reflex activity, this picture is from your book. I think it's kind of funny because it uses an actual hammer instead of a reflex hammer. But reflex activity in a given muscle produces similar activity in its ipsilateral or same side, synergists, muscles working together, and the opposite activity in its ipsilateral antagonist. Thus, the standard tap on the patellar tendon causes not only excitation of quadriceps motor neurons, but also inhibition through an interneuron of motor neurons to the hamstring. This is what your book is telling us. That's why I put in all those other slides to really illustrate it and kind of drive that point home. Okay, so added in here, you can see that muscle spindle is using the 1A afferent, remember. So from chapter 9, our spindles are 1A afferents, our GTOs are the 1Bs. Flexor reflex involves several segments, and all connections are polysynaptic. In the example shown here, a nociceptive fiber from the foot enters the spinal cord at S1 and activates through at least one interneuron. The motor neurons to iliopsoas and hamstring. Okay, so iliopsoas, that major hip flexor, remember, and then hamstring on the back of the upper thigh. Superficial reflexes are elicited by gentle cutaneous stimulation, cutaneous being skin. Okay. Depends on upper motor pathways and cord level reflex arcs. Best known one is going to be our plantar reflex or our Babinski sign. The abdominal reflex was the one that I was like, sometimes this works, sometimes it doesn't. I wouldn't put too much stock into it. But this plantar Babinski sign is gold standard neuro test. Do it for all of your patients. You won't know unless you try it how many positive Babinskis you're going to see, and then you're going to have to chase down why, and then that's going to lead you into helping your patient a whole lot more. So superficial here. So best known plantar reflex, Babinski sign, you could see scraping the bottom of the foot. So starting off at that heel and going up the foot. The normal response would be nothing or the toes going down. Again, this is going to be if someone were to come at you with a punch or a threat and you went out into extension to meet that punch to get hit. The normal response would be to flex and protect. So it is pathological if the Babinski sign is there and you scrape the bottom of the foot and the toes fan upwards. Okay, so that's a positive Babinski, that's an upper motor neuron lesion sign. This is testing the integrity of the cord from about L4 to S2 usually. It can also be brain. Okay, so it could be brain, it could be MS, it could be corticospinal tract, it could from the brain, right? Spinal canal stenosis can also cause a positive Babinski. Okay, so it's not just going to be this cut and dry. So we need to further investigate. If I didn't have an MRI on a patient already and they had a positive Babinski or plantar reflex like this, I'm getting an MRI. Depending on the area, I'm going to go for lumbar area for sure, maybe even a brain, depending on what their other symptoms look like. Stimulus, stroke the lateral aspect of the sole of the foot, response, downward flexion of the toes, damage to the motor cortex or cortical spinal tract, abnormal Babinski. So hallux dorsiflexes, other digits laterally fan out. This is normal in babies up to about a year due to incomplete myelination. So we're not myelinated yet when we're born, and so we're going to see positive Babinski. It's totally normal. That's exactly what you're going to find on every single baby is a positive Babinski sign. So if you have kids or kids in your office, keep doing the Babinski sign and see when it goes away. Okay, so they're just not completely myelinated yet. So that's why we look at demyelinating diseases like MS for when we see a positive Babinski. These abdominal reflexes, that's what I was talking about with the ones where it's like, maybe. I've never really seen them work all that consistently. Test integrity of the cord from T8 to T12 causes contraction of the abdominal muscles and movement of the umbilicus in response to stroking the skin. Okay, so vary in intensity from person to person, absent when cortical spinal lesions are present, or it could just be absent. So this is not sending up a red flag whatsoever. Okay, so I don't even do this one. So a positive Babinski, that sends up a red flag and I'm investigating further, and it would be malpractice if you didn't. I don't even do this one because it doesn't give us that high yield of information. Nerve segments, if you needed to know it for a board question, upper abdomen T7, T9, mid T9, T10, lower abdomen T11, T12. The way to memorize that is the belly button is T10. So no joke, when I was in school, I wrote a 1 on my own belly next to my belly button. So it looked like a 1 and a 0, and that is how still to this day I remember that the belly button, the umbilicus is T10. And then above that, obviously, is going to be T9 and above. Below that, T11 to T12. Hopefully you will now remember that as well. Feel free to draw on your belly button if that's what's going to help you. Some common test questions that we see kind of show up. The cross sections vary by region, okay, so they're not identical from section to section. You saw what that looked like from the cervical cord to thoracic to lumbar to sacral. You can see the description or the picture of it over here on the right, so how they look different, so the gray matter in each area here. Cervical cord has the most white matter. Okay, so cervical cord, most white matter. Okay, look at these dorsal columns. That's even thoracic one. Cervical's up here. There we go. And then lumbar's going to have the least. Gray matter is the largest in the lumbar, then cervical, because it has to innervate the limbs. Thoracic cord has the IML, or the intermedial lateral horn. Good job. You made it through. Just under 2 hours. Keep going, and I'll see you for the next chapter. Email me any questions, comments, or concerns.